For our next session, we have a special guest joining us from the land of Down Under. We welcome Professor Peter Cameron, who will be joining us online to talk about registries and trauma outcomes. A little bit of background regarding our speaker. He is the Chief Investigator of VSTORM, Academic Director of the Alfred Emergency and Trauma Center, and Professor of Emergency and Division Head, Health Service Research, Monash University School of Public Health, and Preventive Medicine, Melbourne, Australia. We welcome Professor Peter Cameron.
So it's the same, it's a pre-recorded lecture. However, if you do have any burning questions, just drop your question in the chat box. Or later, you could also ask during our live Q&A session where he will be joining us online to address your questions.
Everyone, thanks for inviting me to this important meeting in Malaysia. It's a pity I can't be there myself. I haven't been to Malaysia for quite a few years now with COVID, but I'd be interested to see how your trauma systems are developing. I wanted to just talk a little bit in the next few minutes about trauma systems and trauma registries and what we've been doing in Australia. The outline of this talk, I'm just going to talk a bit about what trauma system is, the data we use in Victoria, Australia, and in the UK, and then where to next with regard to how we collect data and use it in our trauma systems. So the Victorian state trauma system has been around now for more than 20 years and fairly explicit aims to reduce morbidity and mortality associated with trauma, get the right patient to the right hospital in the shortest time frame, and look at the patient journey from the time of injury through to pre-hospital care, acute care, rehabilitation, and community integration. Now, many trauma systems say they're a trauma system, but sort of only stop at hospital discharge, but really a lot more to it than just what happens in the hospital. And then we have a statewide trauma registry, which is population-based, which allows us to look at the whole system. Victoria is a nice compact state compared with the rest of Australia, 6.5 million people, most of whom live in Melbourne, in the centre of it. It's quite a big area relative to places like England, but small relative to the rest of Australia. On the upside, we have a single ambulance service, road and air, and 2 adult major trauma services and 1 paediatric service located in Melbourne. We also have compensation, no-fault insurers, and they provide a lot of the finance for injuries, and as well as that, we have a universal healthcare system called Medicare. So, looking at more detail at the map of Victoria, you can see that most of the activity is in the central area of Melbourne, around Port Phillip Bay, and then you've got these far-flung places with relatively low population densities, but of course long travel distances, which make it more difficult for pre-hospital transport. But within the metro area of Melbourne, there's like over 100 k's across, so there are still quite significant pre-hospital transport times. The Victorian state trauma system is based on the patient, as it should be. In the centre, there's the Department of Health and former advisory committee under the department. And then there's the monitoring, which I've mentioned, the Victorian State Trauma Registry, and then an orthopaedic trauma registry. And then there's the ability to link data between ambulance, death registry, and also the insurance companies. And then on the right side, there's statewide education and guidelines and the statewide retrieval and ambulance service. The trauma services themselves are divided into major trauma services, as we mentioned, the two major adult ones and a children's one. There's a spinal unit. We also have a metropolitan neurosurgical service for older people over 65, that they're neurosurgical units that can treat subdurals and so forth in that group. And then there's the metropolitan and regional trauma services and smaller services. In terms of data monitoring, in the centre we have the Victorian State Trauma Registry, and that's over 20 years old now, and that reports to the State Trauma Advisory Committee and back to the Health Services and ultimately to the Department of Health. But the idea is that the data is used to change practice. Over the last 20 years, trauma has changed significantly, and we've written a bit about this, but clearly older fallers are increasing, and that group is driving an increase in trauma numbers and deaths. Now, part of that is the way we measure it in terms of, I think in the past, if someone fell over a nursing home and died, we wouldn't necessarily take them to hospital, whereas now they're all treated in major hospitals virtually. And also we're CT scanning all these patients, which again identifies quite a lot of patients who in the past would not have had such aggressive management. Motor vehicle collisions are decreasing, and importantly, most high energy trauma gets definitive care, more than 90% at the major trauma centres. So looking at the numbers over time, this is for a population of 6.5 million. The numbers are slowly increasing over time. The vast majority go to get their definitive care at a major trauma service, or in some instances metropolitan trauma service, and very few get their treatment in the regional or urgent care centres. The major trauma per 100,000 population is increasing, and as I say, mostly driven by older patients. And this is demonstrated by this graph, and you can see even over the last sort of 5 to 10 years, there's been quite a large increase in this very old age group, the over 85s, people less than 16 and 16 to 44. There's virtually no change, and quite small numbers in terms of population incidence. And this is what's driving it. The low fallers over 64, you can see massive increase even in the last 5 to 10 years, whereas motor vehicles trending down, and things like assaults here and gunshot wounds and so forth are very small numbers. One thing that you need to be aware of in terms of a centralised system is just what effect it has on pre-hospital time. So we've looked at this over many years now, and consistently the median, which is where 50% of patients are dealt with, median time, pre-hospital time, is an hour. That means more than 50% of patients spend an hour getting to hospital. And the 90th percentile, that means 10% of patients spend more than 2 hours. In hospital deaths, interestingly, you know, we like to think our system is constantly improving, but in reality, our adjusted in-hospital death rate hasn't improved over the last 5 to 10 years, and has remained relatively static. This as opposed to the first 10 years of our trauma system, where we had almost a 50% reduction in the odds, the adjusted odds of death. But that is stabilised now and has not improved much further subsequently. We've written a lot about functional outcomes, and we started this 15 to 20 years ago looking at this. And what was important to us was that during that first 10 years with the improvement in survival, we also had an improvement in functional outcomes. This was really important in terms of funding of the trauma system. In terms of the cause of injury, deaths, low falls, as we've mentioned, have driven this significantly over the last 5 to 10 years. Hanging is the area that we don't see a lot of major trauma in hospital, but pre-hospital is actually the second major cause of death, and most of those are self-inflicted hangings. Transport-related going down, firearms are small, drowning, falls. So you can see that this low fall group is really driving our mortality and hospital admissions. And of course, age is what's driving this also. So if you look at the over 85 and older, the proportion that die coming into hospital with major trauma is like 35%. Similarly high, 75 to 85, but less. But once you, in the sort of less than 75 group, the actual death rate for major trauma is not that high. And you can see that in this graph here, you know, very high death rate, very high number of trauma patients who die in this older age group. And in the under 16s, it's very unusual for patients to die. So post-discharge is where I think we have made some improvements and really focusing on, because 90% of the patients survive. And, you know, in terms of the impact on society, this is really important. We've followed different outcomes over time. We started off with the SF12, but now gone to the 12-item HUDAS. We used the EQ5D5 level and the GOSE, a numerical rating scale for pain and return to work and work disability. For PEDS, we used the COSHI score, and obviously we linked to the death registry. But also, in terms of compensation costs and so forth, we're now looking at TAC and Department of Human Services. What we've been able to show is, you know, in the first 10 years, and we had that improvement in death rate, we really made a lot of difference to the burden on society of trauma, and a very significant decrease in the cost per case over those first 10 years. In terms of the different domains, if the long-term health status, what we've found is that there are some important factors that weigh on the outcome. So, you know, mobility, self-care, usual activities, pain or discomfort, anxiety, depression. Now, age is really one of the most, as we've said, important factors in death, but it's also in terms of survival outcomes as well. Interestingly, anxiety and depression goes the opposite way with age. So the older people have less anxiety and depression as they get older, whereas for everything else, pain, mobility, etc., increasing age is bad. Compensation is bad. Giving people money for being sick is bad. Lower socioeconomic status comorbidities, all have a big impact on outcomes. And depending on which domain you're looking at as to some of the other impacts on outcome, but we're finding psychiatric illness, drug and alcohol are really having quite a big impact on our survivor outcomes, and really trying to focus on some more targeted interventions in this group. Just want to talk about, so that's in Victoria. We actually have the National Trauma Registry as well, which allows some benchmarking for in-hospital outcomes across Australia and New Zealand. So that's been going for about 10 years, but it's becoming a more robust database now and has more secure funding. It's a very minimal data set, and I can share with you our national trauma data dictionary if you want, but these are the sort of skeleton data items that we collect. We do not collect post-discharge outcomes for the National Registry because it's just too hard in the current time. We're able to look at hospitals across Australia and New Zealand and look at risk-adjusted length of stay, risk-adjusted mortality, and compare. And these funnel plots are very useful for comparing institutions across the country, across both countries. As you, I think you're getting a talk from the TAN people as well, but TAN has a massive number of clinical indicators which are collected. The problem with this is that it obviously adds to the data burden, and data integrity, unless it's done well, can be difficult. The other problem is that the raw data in itself is not very useful. It's how you use the data. KPIs for things like time to CT scanning, are important for some individuals, a very small number of patients, but it might, if you look at time to CT versus outcome, for example, you'll find that the best outcomes are for patients who took a long time to get to CT because the clinician decided that it wasn't that urgent because they looked that well. So there's a natural confounder in there of clinician judgment for, the cases as to whether they're well or not well. And obviously the more sick the patient looks, the quicker things will happen, and that inevitably results in poor outcomes for patients who are managed most expeditiously. So there's a lot of thought needs to go into which are the important indicators and how you use them. Just reporting on all these indicators without interpretation is, in my mind, a waste of time. So we just need to think about that, and happy to discuss that if that's useful. Presentation of data is critical, and getting the clinicians on board. The clinicians do not like a big table with odds ratios and confidence intervals. They like graphical representations. The caterpillar plots, I think, are quite useful. This is from the UK, using the adjusted survival across hospitals, and that I think clinicians find easy to interpret. Funnel plots, as we mentioned, I think are really useful. VLADs are another way of doing this in a more real-time sort of way. That variable life adjusted displays, and I think can be useful if you have more contemporaneous data. So can we use our data better? I think the electronic medical record gives us significant opportunities. I'm not sure to what extent they're used in Malaysia, but we're now exploring the use of artificial intelligence to drive better ordering and better clinical pathways to support clinical decision making. But it's still early days and still, I think, more of a pilot phase than a mandated phase. Linkage between databases is really important, and you know, again, the electronic medical record gives us some opportunities to do this. The post-discharge comparisons are really useful. The UK has done this well with the SAIL linkage program that Ronan Lyons runs, looking at social security data, you know, which patients end up being out of work and needing ongoing care and so forth. The data from linkage in the UK using their national insurance number and so forth is quite useful. We're doing a little bit of this now in Australia, but I think it's the way of the future because telephone follow-ups and so forth are extremely burdensome. And image transfer protocols between institutions also give us a lot more ability to compare across institutions. We've used, up until now, we've had a very sort of retrospective approach to data use. We, you know, like our trauma registries are 3 to 6 months behind in what's actually happening, just by the nature of patients needing to be discharged before being put on the database. And so if we have more real-time data, we can even use the data for decision support, especially for remote institutions. And really, it often opens up the opportunity for virtual management, a trauma centre without walls, which I think is where the future lies with the use of data across the trauma system. And COVID gave us a chance to trial some of the virtual management. You know, if you think about it, with our cars now, we have the heads-up display telling us whether we're within our lane, you know, whether we're going in the correct speed, all that sort of gear. There's really no reason why we can't do that at a system level across our trauma systems. And to me, this is where trauma registries and trauma monitoring, trauma reporting and trauma analysis and trauma data support are going. I wrote an editorial about this a little while ago, and I think if we need to start thinking about how we're going to do this better. So a trauma system requires data to drive it. The governance structure is critically important. And again, I'm not quite clear on how that works in Malaysia, but certainly needs a bit of thought. Using data well needs to move to real time. Most clinical databases have not kept up with the data science, and we're still sort of using last century's technology. And changing the current paradigm for clinical decision making it will take time. I mean, we've been talking about this for 20 years, but we are starting to get there now. So I hope that has stimulated a bit of thought. I would be interested in what's happening in Malaysia and happy to take any questions in the panel. Thank you very much.